Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is 27th August 2025. This video is on a JACC state-of-the-art review titled The Pathologic Basis and Management of Calcific Aortic Valve Stenosis. The authors are Dr. Milind Desai from Cleveland Clinic and Dr. Eugene Braunwald at the Brigham. Epidemiology and disease burden. What is the prevalence of calcified aortic valve stenosis? More than 1/4 of adults above the age of 65 show aortic valve sclerosis, which can progress to calcific aortic valve stenosis. Severe aortic stenosis causes over 100,000 global deaths annually. What is the prognosis of untreated severe symptomatic aortic stenosis? Median survival is 2 to 5 years after the onset of angina, syncope, or heart failure. What is the standard of care? Surgical aortic valve replacement, or TAVR, transcatheter aortic valve replacement, remain the gold standard. Both are Class 1 recommendations by ACC/AHA and European Society of Cardiology. Why are early stages of calcific aortic valve stenosis clinically significant? Aortic sclerosis and mild to moderate aortic stenosis lack specific guideline-directed therapy, but still carry increased morbidity and mortality. What is the unmet need? No medical therapies exist to prevent a slow progression of calcific aortic valve stenosis, highlighting the need for novel pharmacologic strategies. Pathophysiology of calcified aortic valve stenosis. What drives progression? Oxidative stress, chronic inflammation, lipoprotein deposition, osteogenic signaling, and dystrophic calcification are key mechanisms. What's the role of oxidative stress? Uncoupled nitric oxide synthase activity increases superoxide and hydrogen peroxide, promoting calcification. How does inflammation contribute? Lp(a) deposition and inflammatory cascades drive valvular interstitial cells to differentiate into osteoblast-like cells. What is dystrophic calcification? These are calcium deposits in areas of tissue injury and contribute to progression. What patient-specific factors accelerate disease? Bicuspid aortic valve, chronic kidney disease, radiation history, and female gender with more fibrotic disease patterns. Progression of calcified aortic valve stenosis. What are the phases of calcified aortic valve stenosis progression? Initiation, including endothelial injury, lipid deposition, microcalcification, and propagation, osteogenic Wick activity causing a vicious cycle of calcification. Which risk factors influence progression? Elevated LDL cholesterol, Lp(a), hypertension, smoking, mitochondrial dysfunction, and oxidative stress. How do bicuspid and unicuspid valves differ? The progress is faster due to abnormal flow, Notch1 mutations, and endothelial injury. What's the role of chronic kidney disease? Disturbed calcium phosphorus homeostasis accelerates progression. Why do women often show a fibrotic pattern? Lower androgen exposure may reduce osteoblast activity, leading to less calcification and more fibrosis. Exercise physiology in calcified aortic valve stenosis. How does calcified aortic valve stenosis affect exercise capacity? Patients fail to augment cardiac output, leading to reduced maximal oxygen consumption and impaired exercise tolerance. What happens to stroke volume during progression? Initially maintained, but later stages limit forward cardiac output due to valve narrowing. What structural changes occur in the left ventricle? Progressive hypertrophy, reduced compliance, increased filling pressures, and ischemia during exertion. Why is exercise testing valuable? It can unmask symptoms such as ischemia, pulmonary hypertension, and inability to augment output. What's the link between left ventricular hypertrophy and coronary flow? Impaired coronary flow reserve correlates with hypertrophy, increasing risk of some subendocardial ischemia. Modern classification. What's the modern view of aortic stenosis? Aortic stenosis is not just a valve disease, but includes extravalvular damage, left ventricle, left atrium, pulmonary vasculature, right ventricle. What are the stages of cardiac damage? Stage 0, no damage. Stage 1, LV damage. Stage 2, left atrial and mitral damage. Stage 3, pulmonary hypertension. And stage 4, RV damage. Why is this classification useful? The extent of cardiac damage predicts prognosis and mortality. What did Generou et al. Show? Increase in cardiac damage correlates with higher mortality in partner trial cohorts. What clinical implication arises? Early effective aortic valve replacement may benefit asymptomatic patients with moderate to severe calcified aortic valve stenosis. Unmet needs and failed therapies. Why is watchful waiting problematic? Silent progression to moderate aortic stenosis still increases mortality and reduces quality of life. What are the outcomes of statin ezetimibe trials? Despite lowering LDL cholesterol, they did not slow aortic stenosis progression in the SEAS and the astronomer trials. What about vitamin K2? Vitamin K2 with vitamin D did not slow aortic valve calcification progression in older men with sclerosis. Why do statins fail in calcified aortic valve stenosis? Mechanisms differ from atherosclerosis. Oxidative stress pathways dominate. What remains the clinical gap? Need for agents that target inflammation, oxidative stress, and Lp(a). Emerging therapies. What role do PCSK9 inhibitors play? Evolocumab reduced incidence of calcified aortic valve stenosis by 50% in the exploratory analysis of the Fourier trial. Why is Lp(a) a target? 1/3 of calcified aortic valve stenosis patients have elevated Lp(a), strongly associated with progression. What's the role of atazigawat? Phase 2 trial showed aortic valve calcification progression via soluble guanylate cyclase activation. How do SGLT2 inhibitors help? In TAVR patients, dapagliflozin reduced mortality and worsening heart failure by 28%. What about colchicine? Reduced prosthetic leaflet thickening post-TAVR, but increased stroke risk. Future anti-inflammatory agents are needed. Eponyms and landmark trials. Dr. Eugene Braunwald, the author of this article, is a pioneer in cardiac research. He and John Ross Jr. wrote the classic description of the natural history of aortic stenosis. Landmark trials, SEAS, which showed no benefit of statins in aortic stenosis, simvastatin and ezetimibe. Astronomer, rosuvastatin in aortic stenosis progression, neutral results. Fourier, PCSK9 inhibitor evolocumab reduced incidence of aortic stenosis. Partner trial showed educated us about the classification of cardiac damage. TAVR unload, no benefit of TAVR in moderate aortic stenosis with HFrEF. Emerging trials, Lp(a) Horizon, an antisense oligonucleotide pelacarsen is being studied. Frontier CAVS, Lp(a) lowering with pelacarsen, another trial. CoStar, colchicine in post-TAVR patients. Atazigawat phase 2, soluble guanylate cyclase activator slowed progression of aortic valve calcification. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.